Hello, Melbourne. Very nice to be here. I'm glad that enough of you managed to have an avocado body rub this morning to get here on a Sunday morning. To finish that off with joy juice is really just so much innovation I don't know what to do with myself on the brunch front. I'm Alexander. I'm a doctor in the UK. I'm going to talk about a project that we work on, basically supporting some health system strengthening initiatives in Somaliland. And I'll go into that in a bit more detail, but just first, on my first day of being a junior doctor, the first thing I had to do, because all the other people were in hospitals about 10 years ago, all the other more senior people in the hospital were doing something else. I had to go to cardiac arrest call, and I'd been on the course a few days before, and on the course there's all these things like ABC, airway, breathing, circulation, and it tells you what to do, and they say you have to be very authoritative and tell everyone around the room what they're supposed to do. And I arrived at this patient, had a very horrible condition called Fournier's gangrene, which is gangrene of basically your scrotum, and not something you want to have. Anyway, I arrived, and this poor chap had a cardiac arrest, and all I could remember was my ABC, my sort of flight training, and remembered I needed to be very authoritative, and all these people were standing. I just arrived in London, maybe a day before, and I said to everyone, I was like, you A, B, C, you do this, you do this, you do this. Anyway, it took about half an hour. Unfortunately, alas, it didn't go very successfully. But at the end, I remember that there was a bit that was like something like, don't ever forget to say thanks, and somehow that don't EF something, it works somehow in the acronym, but I can't remember now in retrospect. Anyway, so we all went outside the room, and I looked around at all these people who had instructed what to do and said, thanks very much, good to meet you, thanks very much, good to meet you, thanks very much, good to meet you. And I saw one of their badges, and it said Professor of Intensive Care Medicine. And ever since that moment, I've always been very wary of the audiences to whom I'm talking. And so many of you will know far more about international development than me, so please do bear with me. This first slide is a picture of a patient with schizophrenia in Somalia, taken with consent as far as is possible. And ostensibly, you can see that the conditions for a patient with mental ill health in a place like Somaliland, which I'll talk about in a bit more detail in a moment, are not amazing. So what tends to happen is the families will struggle to manage with them. They'll have lots of problems with the justice system. And then usually what happens, and in actual fact, this is relatively good circumstances in that this chap has a bed and a rug. Often what happens is people are put in a facility where they're chained to the ground in the middle of an open field and given a bowl and occasionally get fed. So the circumstances for mental ill health are not great. Somaliland is a semi-autonomous state in the north of Somalia. Somalia broadly has 3 regions. It has its own government, although it's not officially recognized. It's that bit in red that you can see out there. And it's about the geographic size of France, about 3 million people. And it has one of the most basic and fragile health systems in the world, or the rest of Somalia does as well. It's a kind of interesting case study in as much as, given that it has relatively stable government compared to its neighboring regions, it's given rise to a certain amount of development that might not be seen in analogous circumstances in quite nearby areas. So just quickly to think about what conspires to put this poor chap in a chain. First of all, security. Somalia on the whole is not a place that's well regarded in terms of security. In terms of the treasury, there's all sorts of corruption. They don't have a big GDP. They don't have lots of money. The Ministry of Justice, the prison system for patients who have mental ill health and have committed a crime, is clearly even worse than the circumstance you've just seen there. That's not a patient who's committed a crime. That's just a patient who's been sectioned for mental ill health. Fundamentally, why they don't have any money in the coffers? Well, they don't really trade very much. There's frankincense, myrrh, and goats, and a few other things, but not a lot of trade happening. And the education system, obviously, as is often the case in fragile states, is not what you would find here in Australia. And one very small part of the problem for this guy is that their Ministry of Health is not as strong as it could be, and their system of healthcare is not as strong as it could be. Now, obviously, a whole bunch of other organizations who conspire to determine what the environment is outside the country. So we're talking about quite a complex environment in quite a fragile place. So this is a guy called Jibril. Jibril is a doctor in Somaliland. He was one of the first graduates in the country. We've run a program for 10 years, which I'm about to talk about, but when I arrived there, Jibril was one of the medical students, and actually the first 5 graduates of the country I got to know very well, and since then there are now many graduates, both in medicine, nursing, midwifery, and other places. But Jibril wanted to be a psychiatrist, and there wasn't a psychiatrist, there wasn't anyone to train a psychiatrist, there wasn't any psychiatric facility in his town, there wasn't any psychiatric training in his curriculum, so it's pretty unlikely that he was going to become a psychiatrist. Now, in terms of a health system that's competent to deliver psychiatry, the WHO talks about the building blocks for health system strengthening. So they've got services, financing, information, human resources, technology and medicines, and governance. Now, all of those things are a subset of the activities across the broader system of governance in a place like Somaliland. Within the context of the health system, all of those things have their own challenges. So clearly, there are problems that, on the whole, the world already knows how to solve. So these are not knowledge problems. They're how to deliver healthcare, how to finance healthcare systems, albeit with a degree of localization. Those are things that people know. We run health systems relatively effectively in other parts of the world, and yet this is really it's a question of implementation. So there's a gap really between stuff that the world already knows and what we're capable to do. So to an extent, part of the problem is a problem of implementation. So how do we actually get this stuff to happen? So there was a long-standing link, as there often is, between resource-rich healthcare institutions and the Somaliland health system, where basically a few clinicians would go out a year to Somaliland and deliver various different interventions at different points within the healthcare system. I first went to Somaliland in 2007, at which point this was the sort of activity that was happening. These types of programs occur all over the world, and what tends to happen is you go in, you might deliver some training or teaching, maybe 2 or 3 people go 2 or 3 times a year, and they're able to give a small intervention for a period of time, and by the time they come back, the environment's changed, it's not very stable, it's difficult to understand exactly what's happening. And there's obviously a large economic, financial, and personnel cost. So in 2008, just after I first went there, we basically wanted to create a technology stack that would enable us to organize, scale up, and monitor and evaluate the programs of health system strengthening. So different types of activity, which I'll talk about in a minute, but basically to create a window through technology into the Somaliland health system. So at that point, there was a couple of internet connections, very different environment in the health system in Somaliland. And probably it was a slightly random thing to do to try to use that, therefore, as a channel to conduit to communicate with the health system. And what we did was create a window between them and the health system of South London. So Guy's, King's and St Thomas's hospitals, if you've heard of them, and the King's College London, South London, and the Maudsley, which is the mental health facility. And what that enabled us to do was unlock the capability, human capital, within 500 volunteers and engage many more people at the other end, and engage people on a daily basis. So rather than 2 or 3 people going every once in a while, we were able to sustain programs of daily engagement with the Somaliland health system, with large pools of technical resource from across a large campus in the UK, injecting that into the Somaliland health system. So we basically built a piece of technology. It's gone through several different iterations, but it looks a lot like a kind of online classroom meeting space coupled to a social network and data analytics platform. And what we did was we created a series of different programs using this technology as a tool for communication in order to support those health system strengthening activities. So I'm going to illustrate that through the story of Jibril. So in 2008, as I said, there was a couple of internet connections in the healthcare system. And at that point, people were going backwards and forwards of doing teaching. We decided we'd start a program very simply. This was a bit unstrategic potentially, but what we did was we decided we would teach medicine, surgery, psychiatry, pediatrics, obs and gynae online once a week to each of the final year medical students, just to try to create some platform, experiment, and see where we got to. At that point, there was much excitement about the fact that we were using a bit of technology to do this, but there was also lots of criticism. People said that there was an agenda coming from outside, that not all people were having access to the intervention, that there were certain groups of elites that were getting access to the intervention, that there were potential misalignments with the existing curriculum, etc. So just to demonstrate the point, this has been a process of perpetual learning in response to lots and lots of challenges and difficulties. So it's a really agile project that we've tried to develop across the course of the last decade. But in 2010, can I go back? Hopefully I can go back. So in 2010, Jibril graduated. Now, he graduated, this was the first time there had been medical graduates in the country. So they graduated into a system in which there was nobody to supervise them, to teach them, to train them, to support them. So the next thing was to take these people who were in an internship program, which was in part created through this broader program, and to provide clinical supervision. So Jibril wanted to be a psychiatrist. As I said earlier, we needed to provide a mechanism where Jibril would be able to talk about, amongst other disciplines that he was doing during his internship, various different psychiatric cases. So we gave him a program of supervision. We then developed a program to support clinical supervisors. So these were clinicians who worked within the healthcare system in Somaliland to support the people who were working on the ground in the internship program. And that, as I said, was part of a broader internship program. So first step was to say, let's engage and put a little bit of psychiatry into the curriculum in the Somaliland health setting. Then, once they've graduated, let's try and support these students by giving them support in subjects they wouldn't otherwise have support from. 2012, Jibril, in a fledgling health system like Somaliland, somebody very rapidly rises through the ranks. So Jibril becomes a teacher, and he's teaching everybody else how to do this stuff. So all of a sudden, Jibril's teaching all the other students about all of this psychiatric stuff, amongst other things. And so what we did was, at that point, having kept in place all the previous interventions for the cohorts of people that were now going through the earlier stages of their training, what we did was we put in place a Teaching the Teachers course, and then we recognized that a sort of strategic intervention to bolster and improve the capacity in the educational system for the medical cadre of healthcare workers was to introduce structured international standard examinations. So we introduced a program of OSCE exams, which those of you who are medical students will know about. Those of you who live with medical students will probably know about as well. And the next thing was to say, well, now people have graduated, they need to have a good standard of their final examination. So we provided international external examiners in order to support a process of standardization. Then more formally, we worked with the Somaliland faculty to put in place within the two principal medical schools psychiatry such that it was written into the medical and nursing curriculum in Somaliland. So now there's several different levels of intervention that we were able to make. Next, Jibril's kind of a leader now. He's not very far out of the system, but he's a real leader. And in his town, Boroma, there's not a mental health department. So we support Jibril to start an outpatient department. Partly through a broader program, he gets financing to construct a mental health clinic, which now sees 500 patients a year. And as part of that, we put in place a bunch of programs to support people like Jibril to build quality improvement initiatives, which I'll go into in a moment. As part of the outreach of that clinic, Jibril was able to develop the first school and maternal health service in the region. So this was a new way of engaging people with difficult mental health problems that otherwise previously hadn't really been considered. And then lastly, to provide forensic support to Boroma Prison, which in a way is the group of people for whom the conditions are the most challenging. And then 2017, Jibril's been now all over the world, worked for the WHO, et cetera, et cetera, et cetera. What we did was we put in a program of leadership and management training. So developed a leadership and management course, which we're now evolving to make into an online master's course. And then we recognized that actually they need data to do some of the research. Obviously, they recognize that themselves as well and have worked with a number of different stakeholders to do that. But we did a baseline capacity assessment of the research capacity in the country. So we basically did a systematic review looking at what had been done, who the stakeholders were, how we would support the building of research capacity. And then we decided the next thing was, well, we need research capacity, so we started a research capacity course. So this was a way of people learning basic research skills and then conducting through that small dissertations, audits, projects of different descriptions, in order that each of those people would then deliver a strategic intervention in the Somaliland health system. And as a consequence of kind of brought to bear a number of different publications with Somaliland co-authors. So obviously that was Jibril. Jibril wants to be a psychiatrist. He's now largely doing public health. But Jibril was one person. There was obviously the need to do that in different disciplines. So this is Mariam. Mariam was another person who we supported with very analogous interventions in medicine. This is Moomin. Moomin's a surgeon. Abdi Rahman, he's a pediatrician, and this is Hoden, who's in obstetrics and gynecology. So basically, we recognized that we needed to develop programs for each of those cohorts as they evolved through the system, so responding to different need across time, but also that there were different cadres of that there were different specialties within the healthcare system that we needed to support the creation of structures to enable the development of those professional cadres in Somaliland. Now, obviously, that's talking mainly about doctors. We have gone on to develop programs and now are doing that more formally in the course of our next program, but we have made some interventions both with the nurses, midwives, lab technicians, and the administrators and faculty within the university. So this is an attempt to systemically bolster, where possible, strategically as strategically as possible, the human resources system within Somaliland. So by way of example, we've introduced various different bits of education into the curriculum, examinations of different sort, and education and health system strengthening interventions for 100% of the healthcare workers in the medical cadre that have graduated, and the majority of the BSc nursing students who've graduated. So essentially, these programs of intervention designed across time to support changing need in a fragile environment. So just to finish off, we've, in the course of the last year, been awarded a grant from UK Aid called SPHERE, which is Strategic Partnerships in Higher Education, Innovation and Reform, very punchy. Basically, the purpose of this grant was to support programs between institutions of supporting capacity building within higher education institutions. Rather than specifically framed around health systems, this is more about supporting systems of education. So we've got a 5-year program grant, is £3.1 million, and then we've got £1.5 million of in-kind technical expertise being contributed into the system. And that program is going to reflect some of what we've done before, but with some modifications. So it involves training of the healthcare professionals, supporting curricular development and faculty development within the health education institutions, supporting policy development within the Nursing and Midwifery Association and the Medical Association, making sure that the types of systems of support for postgraduate education are in place, and then working with the Ministry and the National Health Professions Council, which is the kind of regulatory body, to try to make sure that the appropriate regulatory systems are in place, both for people and institutions, to ensure that they have the right checklists, the right systems of governance to determine that. And then lastly, a bit of work with providers, but most of our work is with the other elements of the healthcare system. So just to finish, clearly there's a lot conspiring against this guy, and the purpose of my talk is in part to encourage a kind of process of systemic thinking, where are the problems, and then a process of sort of strategic thought in identifying the best way to unlock solutions to those problems. I originally started training in oncology in Oxford, and I wasn't particularly enjoying it. And I woke up in the middle of the night one night and having had a nightmare that I had a complaint letter from a patient, and that I had responded to the complaint letter with a letter that I'd written in emojis. And at that point I realized, I think I need to do something a bit different. This is not going that well for me. And I started to pursue this with a little bit more gusto. But I have to say, this for me is something I'm sort of deeply passionate about. It at times is very, very challenging, and many times you don't want to keep doing it, but on the whole, it's been an absolutely amazing experience. And I know the Global Ideas Forum is in part to encourage people to go off and try and do different stuff and build relationships with different people. But I think the key thing from the talk, hopefully, is to just go and listen to people, have a go, explore, and enjoy yourselves, and make sure that you don't sit in circumstances that will make you dream about emoji letters. Thank you.